Hello, my name is Elena Dumitru, and I am working as an emergency physician in Department for Emergency Situation. Today, I am excited to introduce you to KnowEMS project, an European Union funded project. As part of this, our organization, Department for Emergency Situation, is proud to be involved in performing new ways to improve and develop emergency response by sharing this webinar on sepsis management. I have the pleasure to invite our experts from Germany, Professor Latasch, from Spain, Dr. Nanwani, from Portugal, Dr. Esteves, and from Israel, Dr. Kaplan. Who will present physiopathological aspects, protocols, guidelines, and innovation in management of sepsis in pre-hospital. So stay with us along this webinar.
So a big hello from me as well, and I want to tell you something about the reason why we're here, the project KnowEMS. Some of you may already know this, some may know this presentation, but just give me a few minutes and to talk about this. If it's technically working here. Now you should see my presentation in perfect presentation mode as it should be. Sorry for the interruption. So the project is called KnowEMS, and we are a consortium made out of 7 partners. We have some from France, SFMC and APHP. We have one from Spain, it's SAMUPC. We have Portuguese colleagues from ENEM. As Germans, the Ioannita, colleagues from Romania, DSU, and colleagues from Israel, from Magen David Adom. And the whole background of this project is another project called KnowFear, and it was the full name is Network of Practitioners for Emergency and Medical Systems and Critical Care. And during the pandemic, it was made clear that countries are connected and could learn so much from each other, like indicating priorities for standardization and support quick wins and practical short-term results, and implement those transactional dynamic portal providing fora, a catalog, marketplace, and flexibility to address new threats. And out of this, KnowEMS was created. And what do? We do this. We do monthly webinars to interesting topics held on the very first Thursday of every month. And for example, the past topics have been the EMS organizations and the Madrid metro bombing, management of burn mass incidents, and emergency services and mass gathering events. If you missed one of those webinars, check out our YouTube channel. We are recording this and upload them every time. And according to the topics you see, we have experts in our team, we have experts in our contacts, and can provide you with information from the very first line and with a lot of expertise behind that. So this is high quality input. And we're always looking for new topics. So if you want to talk about something or want to hear more about it, and just scan this QR code, I will post it in the chat afterwards as well, and fill in your wishes. We are totally capable of that we can look what we can do. If you wish for a topic, to contact our contacts, and maybe your topic will come true, and we will talk about this in a few months. And if you don't want to miss anything and didn't already do that, become a part of our KnowEMS network, scan this other QR code, and then you won't miss any recording, any webinar, and so on. Thank you.
Thank you, Michelle. will start this webinar with Professor Dr. Latasch with Sepsis Unveiled, the physiology and pathology. This is a great opportunity to engage in a depth of understanding this critical subject of sepsis. Thank you, Professor. You have the word. Professor is working in an anesthesia center in Frankfurt.
Not anymore, but that's my
No?
medical background.
Oh,
I mean, I'm still involved in intensive care and emergency medicine, but that's just the medical background. I would like to introduce the first of all pathophysiology of sepsis, but not going into deep details because you'll see in a moment why. Two things: please don't be overwhelmed from the written parts because I'll pick out what's really important. And one more thing, the drawings which I used, I will put on later the literature of the research where I took the drawings from because they are so good. It would take probably weeks until I would draw something like this, and they're there. So please stay with me. Okay, Michelle, first, next slide, please. Okay, in the meantime, we have found a sentence what defines sepsis. Sepsis is defined, the pathophysiology of a disease includes an inflammatory response that simulates a complex interaction between endothelial complements with associated coagulation abnormalities. And actually, everything is already written in this one sentence. We know, or it said that the endothelial, which is the interior of vessels, is attacked, and that we will face coagulations abnormality. That means of all what happens, you either get bleeding or you get clotting or whatever. Just to have a look at the figures, these are the latest figures which I could found. That was from 2017. 11 million deaths are caused by the syndrome, accounting up to nearly 20% of all deaths worldwide. And yes, sepsis, because of the treatment which we have today, but which is not perfect, it's still going down. But if you reach the state of a septic shock, you still have mortality rates up to 60%. Normally, you have the endothelium, which is the inner side of the vessel. There's a balance between coagulations and fibrinolysis. That means we're in a good harmony so that we don't bleed automatically or that we don't clot automatically. And the endothelium, for instance, synthesizes molecules which probably nearly everybody has heard of, like the Willebrand factor, tissue factor, plasminogen activator, inhibitor type, something like this, which will be all not really destroyed, but which will be very damaged once the sepsis starts. So hyperinflammation normally causes what we call a cytokine storm, which damages the endothelium, causing that the vascular tone, that means the size of the vessel, for instance, or that the vessel even can react going wide or going small, is dysregulated. And you get an impaired permeability, which causes edema, because once the permeability is not what it is, it will leak and let fluid for whatever kind into the vessel. We also note that if you have an impaired oxygen delivery, it fails to meet the oxygen demand, which rises, and this is one of the major factors in lab, which we will always check, is lactate. It will rise or it will cause lactate acidosis. The immune system, on the other side, is specific to certain receptors. And we always thought that this cytokine storm is only by pro-inflammatory mediators, but we know in the meantime that the overall picture is a much bigger one. Please, next slide. Michelle, okay. You please don't look at what's in here, you know. What is important is if you look down there, you see whatever happens inside the vessel or the endothelium. There you see, for instance, increased permeability, vascular leak, and tissue edema, all things which happens because the endothelium is damaged. You will see that you have vasodilation. That means the arterial vessel will change. You have leukocyte plugging on one side. You have stopped capillary flow, but then on the other side, you have much more coagulation, which happens then on the other side of the vessel. Next slide, please. And after that, there will be no more typing or no more lines, so please don't be afraid. Okay, so what we have is we have increased vascular permeability, we have vascular leaks, and we have host tissue damage. And of course, this not stays only inside the vessel, because every organ which we have is blooded or is infused by blood. So of course, what's going to happen is sooner or later we're going to see edema in the brain, lung, and liver. We see blood-brain barrier damage breaking down, which means we will see neurological damage, but this is also in septic shock, like septic encephalopathy, but I will tell you a few words after that. To this problem, there are three major problems with septic diagnosis. The first thing is clinical symptoms are not specific to sepsis. At least I haven't found any symptom which is really showing that we deal with sepsis. Then no biomarker has sufficient sensitivity. We have looked through the last 10 years. We have found a lot. I'll show you in a second. But none shows really sensitivity or to identify sepsis. And it's a symptom or a syndrome with no unifying cause. That means there's always several factors involved. It's not once you have diabetes, you get sepsis, or once you cut yourself, you get sepsis. No, it's a lot of factors, really. And just to give you some hints, when you hear about it, the clinical transition from infection to sepsis is termed time zero. Often we see that there's a reduced capillary refill time. We see an increased respiratory rate once you're going into sepsis and altered mental state. But even if you find this is not 100% symptoms that you are going for sepsis. And forget about those two, because I'll show that in a second. There's not the pharmacology, for instance, which we have to treat it, is really limited, and we still rely on things or on sum ups which have been created in the last 30 years. Next, please. Next slide, Michelle. Please don't start reading it. This is just to show you, because we're just talking a minute ago about biomarkers. You see this is a table which started in 2013, and it's up to 221, and you can see biomarkers from head to the toe. But none of these, even if they found another one and another one and another one, none of this is specific for sepsis. Next slide, please. This once more, there you see time zero. About so far, I will only last a few words because Toma, I think, has something more to say. But there you can see a collection of what really happens. You have the endothelial activation, which then causes a microvascular dysfunction, bleeding, not bleeding, clotting, whatever. The immune cells start working, and at the end, you're going to see a multiple organ failure. Please, next slide. This is a short version, like infection starts. You have macrovascular occlusions, you have vascular instability, you get coagulopathy, you get a capillary leak, you get tissue hypoxia, you get fever. What this causes, you're going into sepsis. And as you can see here, sepsis really hits everything: cardiovascular, respiratory, neurological, renal, and hepatic. Next slide, please. And not only like this, but there you can see what could happen to every organ or to every system which you look at. Cardiovascular system, hypotension, lactate level starts, altered echocardiography variables, hepatic system, renal system, neurological system, respiratory system. And these are all the organs which are negatively involved after the sepsis start. Next slide, please. Okay, you remember there were 3 points, and one of the 3 points was the clinical symptoms are not specific to sepsis, whatever we have today. But as doctors, we start looking and looking and looking and try to find at least something which give us a hint. So one of the hints which were brought up a while ago is called SOFA, Sequential Organ Failure Assessment. And as you can see here, there are several points like bilirubin, platelets, creatinine, mean arterial pressure, and all of them have a score from 1 to 4. And officially, the saying is that if you have less than a score of 9 with SOFA, then the mortality is under 33%. If you have a SOFA of over 11%, of 11 points, predicted mortality could go up to 95%. Of course, as doctors, we don't like to have only one of these tables, so we created another one, SEERS, where you only need 2 of the criteria with temperature, heartbeat, white blood counter, and respiratory rate. And we are saying that if you have more than 2 criteria, if you have 2 or more criteria, you are going into sepsis. Next slide, please. And of course, we're always not satisfied. So we started at one point saying SOFA is too complicated or too much values. So what is the next point? The next point, somebody came up with Q SOFA. So what is Q? It's called quick SOFA. That's the Q. And there you only have, they downsized it to three points actually: hypotension, altered mental status, and tachypnea. That means respiratory rate, how much. And as you can see on the side, it says if you have respiratory rate over 22 per minute, if you have altered mental state or systolic blood pressure, which is lower than 100, if you have 2 of those criteria, or if you have even 3, they tell you it's sepsis. But in the meantime, we found several things. That's what I call the buts contra. That SOFA is not really the 100% measurement, because you can see it has restriction. In some patient, it does not give you the exact value. The blood count cannot be used in chemotherapy. And so you see that negative scoma on the other side, even if you look at SOFA and you get, or on Q SOFA, and if you get less than 2 points of this, please don't delay the treatment. Start with the treatment. Next slide, please. Next slide, please. There you see that where the research goes on for the last 30 years. You see 2005, 2013, 2018. If you read something today like sepsis 2 or sepsis 3, that's the relation to those creation there, which for an association which took part in 2018, 2013, and in 2005. If you see the upper part, you see not much has changed in 30 years. Only the 24-hour bundle is no longer recommended. So please go to the next one. Next slide, please. And here I only give you like an overview. Fluid resuscitation we have found several treatment which we don't use or only as second opinion or third opinion. In the meantime, we're saying crystalloids would come first instead of saline, even ringer lactate, but the use of starch and gelatines are not recommended anymore. Then if you go to the what we call fluid resuscitation, because you need to keep up the blood pressure values. There you can see that there are certain borders which we would like to have: central venous pressure between 8 to 12, mean arterial pressure if possible over 65. So you keep on pushing, and if fluid is not enough, you go to the vasopressors. And there you also see that in the meantime, we have found which one works more or better than the other one. Steroids only in the meantime, because in 2005, everybody said, okay, let's use steroid. In the meantime, we said only those patients refractory to volume resuscitation and vasopressor therapy. Next and last, I think. No, but that's the before the last one. There's internationally, it's called Surviving Sepsis Campaign. This is where all the expert meets and they talk about it. And as you can see, you have a 3-hour bundle, which has to be done in the hospital, or which should be done. You have a 6-hour bundle. And we have found, what we should do after 3 hours or after 6 hours. And next, please. This is
we need to come to an end.
Yes, we are. This is an overview which we will send out because this is really showing what you should do in 3 hours, 6 hours, 12 hours. And the last one, please. I wrote down, is this the promised land? Because since 2017, we have started looking at certain factors. And as you can see, there are a lot. Maybe we can protect the endothelial, or we can reverse immunosuppression or whatever. I can't tell you, and I hope today to hear if any of these medications or if any of research has found a positive effect. Thank you.
Thank you very much, Professor. It's really a great presentation, I must say. You reach all my points, all my questions. You were very explicit, a real course for everybody. All of us who maybe we forgot some of them, you reminded us everything that was needed to know. Thank you very much. It was a great presentation.
Thank you.
And now I will ask if there are any question, or we are waiting at the end to put this question from the audience.
I would suggest, that's just my suggestion, because some of the points which the other colleagues will say will be probably like an overcut. So it could be that some of the questions which are already there may be answered by Toma or
Yes.
So it's
I agree.
Up to you.
So we will let the question at the end. So we will try to start the next presentation. I have the pleasure to invite Dr. Nanwani, which will discuss the essential practices and protocols for managing patients in pre-hospital.
Okay, I have to apologize for Dr. Kapil because he has had a last-minute emergency and maybe will not able to make this presentation. Therefore, I will make instead. If
Thank you very much.
Okay. My name. Can you, Elena? Can you share the presentation for me, please?
I don't have it, but I think that Michelle can help you.
I will do it.
Okay. Thank you, Michelle.
Paloma, do you want to let this presentation the last one, so maybe your colleague will come, or
okay, maybe
I don't know.
I can wait to the
If
the
you want,
next.
we can present now. I don't know if you think
Let's-
that.
No, I
do
don't
it
care.
to-
I don't care. I'm ready.
Okay, you can
So,
present then.
No,
okay.
Paloma, I don't have the presentation.
Really?
So let's do it last, maybe.
Okay. I sent in this morning to Jaime and to Elena or Andra, to Andra.
I don't have it.
Okay. Let me share window, webinar on sepsis. But I don't know how to share the presentation in Zoom in the presentation mode. Let me try.
Compartir, maybe?
Yeah, but not in, okay. Do you
Okay,
see? Okay, so.
It's okay now, Paloma.
No, I see the presentation in
yes, we can see it. It's
full
really
screen.
good. Yes.
Yeah, it's okay.
Okay. Okay, good evening. For those of you who don't know me, my name is Paloma Rey. I'm from SAMUR Civil Protection, which is an EMS in the city of Madrid. So where do we start in this presentation? So sepsis is a life-threatening, time-sensitive medical emergency that affects a great amount of people every year and causing an important amount of deaths. In general, emergency medical services respond to around 40% of all septic patients. This fact justifies the existence of the Survival Sepsis campaign. I'm not going through because Professor Leo already did it, but I want to say that these bundles are only focused on the hospital setting. So let's get out of the hospital and how can we identify sepsis in the pre-hospital setting? So there is quite a lot of scales in the scientific market that have been used to identify septic patients. And for sure you are familiar with most of them. So we are going to focus mainly on the three scales that gather up most of the evidence, and these are PRESEP, pre-hospital early sepsis detection. This is an early warning scoring system designed to identify septic patients in the pre-hospital setting. I'm not going through the scales because also Professor Leo did it really well before. And the QSOFA is the same. I'm not going through this anymore. And News 2. For us, News 2 scale is this scale consider viral and certain clinical aspects of the patient and is able to identify 1/3 to half of a sepsis case. When comparing News 2 and Quick SOFA, News showed better sensitivity, accuracy, and negative predictive value than QSOFA for the early detection of sepsis in an emergency department environment. On the other hand, QSOFA show an excellent positive predictive value. So probably the use of both scores for the detection of sepsis may best serve the evaluation and management of this type of patients. Okay, we know about the scales right now. Many pre-hospital EMS services such as SAMUR have the possibility of labs results. Do they really add on? Probably Professor Leo in his presentation said that no biomarker has sufficient sensitivity to identify sepsis. But for us, the most used biomarker is lactate, which is associated with a higher mortality in these patients. Besides, a contributor to metabolic acidosis and a greater negative base excess that may aid in early recognition of a septic scenario with increased mortality rate. So we got our scales, we got our labs. We can probably identify our septic patient quite reasonably in the pre-hospital scenario, but does it really make sense to implement an EMS protocol to improve its recognition? Well, it seems that having a clinical criteria protocol increases diagnosis and fastens antibiotic administration, although no difference in mortality or hospital state are shown. It seems that the fact of having a protocol increases our awareness and make us think of sepsis compared to not having a protocol. So what about antibiotics in the pre-hospital settings? Well, we have read about a meta-analysis that reveals that receiving pre-hospital antibiotics can significantly lower mortality in sepsis patients compared to patients who do not receive pre-hospital antibiotics. Although more studies are required to confirm these results. So considering the previous slides, what do we do in SAMUR? Our objective is to detect septic patients as early as possible, standardize their management, and optimize the hospital transfer. To achieve these objectives, we need a higher degree of suspicion. So when at least 2 of the first 3 factors are associated with fever, an advanced life support unit is activated with a specific code, TUOSIS code 3.18, but it's okay. We activate the code sepsis when we find a quick SOFA scale greater than 2, along with an infection-related clinical history, focusing on the patient's environment, comorbidities, prior treatments, and recent surgeries, with maintaining an especially high suspicion in socially isolated patients such as alcoholic or elderly patients. Okay, and IV access for crystalloids, oxygen and blood gas analysis is performed to confirm our suspicion and start treatment. And as we saw previously, NEWS 2 scale is used in the follow-up of the patient. Other intervention such airway isolation, early vasopressures, and metabolic acidosis corrections are performed depending on the case scenario. Hospital transfer is performed always with prior notification to the emergency department, the hospital. So based on our protocol, we can probably say as a plus point that it takes into account the current evidence, quick SOFA, clinical impressions, and news to scale in the follow-up. And this is everything. Thank you for listening to me, and sorry again for Dr. Kapil's absence.
Thank you very much for your presentation, Paloma, and that you were rescuing us today with this presentation. We hope that in the future your colleague will be part of one of our webinars.
Of course.
Thank you very much. So further, I invite Dr. Maria Adelaide Esteves from Portuguese INEM, which will who will present us the Portuguese Sepsis Care Process in pre-hospital setting. Dr. Esteves, you can proceed.
Okay, I was without microphone, so I'm sorry. Can you hear me now, right? You can hear me now?
Yes, we can hear you.
Cool. So I'm going to, I guess you are seeing my laptop. Can you see the presentation now?
Yes, we can see the
Okay, cool. Thank you. Thank you. So good afternoon. My name is Adelaide, and I'm one of INEM physicians. I'm currently the head of our sepsis team, and it will be my pleasure to present you today how we deal with sepsis in the Portuguese pre-hospital setting. So I would like to greet my fellow speakers and you, Elena, and I would like to thank Michelle for the coordination of this amazing project. So firstly, I will contextualize the reality of our country regarding sepsis. Then I will mention what the EMS teams do when there's a suspicion of sepsis and how our pre-alarm actually works. And lastly, I'll present the work my awesome teams does and the quality indicators that we track regularly. So as it happens worldwide, in Portugal, we have a growing incidence of sepsis up to 1.5% each year. And as such, the admission it is the admission diagnosis in 22% of ICU admissions, leading to high hospital mortality around 40%. And this number is even higher when the diagnosis is septic shock. And as it is the case worldwide, sepsis entails high healthcare costs in Portugal, which can be divided between direct costs, costs related to hospital readmission, and survivors after effects. There was an increase of direct sepsis costs over 10% in the last decade, with a significant impact from the COVID-19 pandemic, as we know. And it is estimated that the cost of a septic patient in the European Union is on average almost 49,000 euros. So this is really big thing. Our intervention in the pre-hospital Portuguese setting is based on a recommendation made by our national guidelines, launched in 2016 and revised the following year. And it defines basically sepsis teams and criteria to identify suspected and confirmed cases in either the hospital and the pre-hospital context. So this recommendation says that the suspected case of sepsis identification begins with a temperature change associated with focal symptoms, suggesting the source of infection. With this, we have systemic inflammation signs, as it is tachycardia with hyperperfusion or tachypnea, and to be confirmed as sepsis, the suspected case has to meet at least one severity criterion, as it is an hypotensive patient with no exclusion criteria. Until the end of 2022, our sepsis alarm met our national criteria, namely the temperature change with inflammation signs and focal symptoms. However, we found that our yearly number was very low. So we proposed an alteration regarding high sensitivity for sepsis detection. And so since 2023 and currently, we use the same criteria, but with or instead of and, meaning temperature change or focal symptoms with systemic inflammation or severity criterion. And this we have a much bigger sample with high sensitivity, but with low specificity. And as Paloma was saying, and the Professor Latasch was saying, Professor Leo was saying, we don't have the best marker to find out what's the best alarm. And so now we're starting a prospective multicentric study within our country with 3 hospitals, and one of the objectives being to find out what's the best criteria to signalize sepsis in pre-hospital Portuguese setting. Regardless, our informatic application for clinical records, named iTeams, we have here the logo. This application launches the alarm automatically as long as the information is correctly filled. And regardless, the coordinating doctor within the National Coordinating Center, the CODU, is the one who confirms that it is in fact a true sepsis alarm and connects with the receiving hospital so that patient handover is correctly made. And whatever the team involved, we use the new scale to assess severity of the patient. Okay, considering the sepsis management, our basic life support teams with special INM technicians, medical emergency firefighters or Red Cross teams can administer oxygen therapy if the patient has low oxygen saturation and can position patients with low blood pressure. However, if the patient is unstable, when the data is passed to the coordinating doctor within the CODU, an advanced team can be dispatched to stabilize the patient on site. All our differentiated teams can make the same BLS approach, and further, the ILS teams that have nurses can give the first fluid challenge to 150 milliliters and up to 20 milliliters per kilo. And if needed, the following bolus has to be discussed and validated by the regulating doctor in CODU, who can also indicate the administration of noradrenaline. And these teams have also available non-invasive ventilation in the form of SPAP with ventomasks. Our ALS teams with a physician and a nurse can manage the septic patient as it will be managed in a hospital setting. Some teams have POCUS training and apparels, and as well blood gas analysis so that selected can be assessed. However, it is important to mention that either blood cultures nor antibiotics are available in the Portuguese pre-hospital setting, and not as happens with Paloma, with SAMU, we have longer distances to hospital. We have as long as 2 hours, 2.5 hours to the nearest hospital, even though our country is very small. But this is, we know that this is a limitation in our approach. The CODU coordinating doctor receives the iTeam alarms and manages them. He can contact the team to anticipate any necessity in the field or to ask for relevant information about the patient. He can confirm or refute the sepsis alarm, indicate the dispatch of an ILS or ALS team if needed, validate ILS drugs or procedures according to protocols, and refers the patients to appropriate hospital. So this represents the current sepsis workflow that works in the EMS Portuguese context. Basically sums up what I've been talking about in the previous slides. And so this is part of the NAM sepsis team, my awesome team, which I'm honored to present. This team has 5 nurses, and as physicians, me and Dr. Ana Correia, who is our medical consultant. Our main goal is to enhance pre-hospital sepsis care through evidence-based interventions and to contribute with peer-reviewed evidence to the field. As an example, I bring some of the indicators that we monitor with 224 national results. We make this exercise nationally and then regionally and by the type of team involved as BLS, ILS, and ALS teams. These are some of the activities that we perform. We're involved in peer training, developing internal and public sepsis sensitization campaigns, and we're currently in the process of publishing our first scientific article. This is it. I end with another photograph of my beautiful city, Porto, and thank you for your attention.
Thank you very much for your beautiful presentation. Thank you that you are sharing with us your experience and your way that you are perceiving and treating sepsis in Portugal. Thank you very much. So we have reached the last presentation. I have the pleasure to invite Mr. Tomer Kaplan, the Director of Quality Assurance of Magen David Adom, Innovation in Sepsis Management in the Pre-Hospital Setting.
Hello, everyone. Let me just share the presentation first. Second.
So I want to thank all of you that you were able to respect the time and we don't have delays for the moment.
All right. Can you see my screen?
Yes, we can see your screen.
All right.
Yes, now it's better.
Yep. So hi, everyone. My name is Tomer. I'm the head of the Quality Assurance Patient Safety Department in MDA, working for the medical division. I'm going to present MDA, I would say, way of managing or addressing or maybe even attacking sepsis in the pre-hospital part of Israel. So as my colleague says before, I'm not going to repeat everything, but we understand that it's an emergency that needs to be identified and treated early. It kills a lot of people. I think it's one of the leading death cause, especially in hospital, of patients. And we know that early diagnosis and rapid treatment, and sometimes even aggressive treatment, can reduce the mortality and morbidity of those patients. So on our side, on the pre-hospital side, we try to address the things that kills earlier and that we can affect earlier and easiest for us, because we don't have the permission to do everything we want. So as Professor Leo and Paloma said before, we know the mechanism, and since the immune gang and the cytokines causes also vasodilatation and increased permeability, which leads further to fluid shift into the interstitial space and lower the effective circulating volume. So I would say the major part of our protocol addresses that side of the treatment, but as you will see soon, we also treat other factors. So the main thing we do in our treatment protocol is first aggressive but cautious fluid resuscitation. I think it was Professor Leo that said before, we started the treatment using saline because this is what we normally use. But since the evidence shows that salines saves less life than Hartmann, Ringer is like that. And not only that, Ringer have the ability to treat metabolic acidosis better. And also, when you give a large amount of saline, you get hyperchloremic metabolic acidosis. So we shifted and we're not using saline anymore. We're using Hartmann solution now. In the side of vasopressors, we don't have all the alternatives in Israel. So in the pre-hospital setting, we only have epinephrine and dopamine. And also epinephrine is better in treating septic patients, especially septic shock patients. Actually, dopamine is no longer recommended for the treatment of septic shock. So what we do, we use epinephrine, 10 to 20 micrograms. The fluid resuscitation, what we usually do, we give 30 mils per kilo for the first hour, but we give it in boluses of 250 to 500 milliliters, monitoring the patient situation because we don't want the patient to get into cardiogenic heart failure. We also do fever control. And something we're examining is the early administration of antibiotics in the pre-hospital settings. It's something that we're examining in front of the Israeli Ministry of Health. So far, we haven't decided if we're going to go for it. Some research says that it shows some benefit, but it's not absolute, so it's not something we started doing. And of course, since the identification and the early treatment is so important, so hospital alert is part of our, I would say, even treatment. As Professor Leo said, we also use the Q SOFA. I will show you in a minute how it works and how we use it. So what we did in Israel, I think we discussed it in previous sessions of the KnowEMS, but we have KPIs that are measured throughout the health system. So the Ministry of Health identified fields that they want to measure where easy intervention or relatively easy intervention can save lives, and we focus on those KPIs. So for the pre-hospital side in Israel, we have, I would go quickly on the KPIs that we present. We have on cardiac arrest, we are measured on dispatch-assisted CPR, the percentage of arrests that were assisted by a dispatcher. We have a survival rate to hospital admissions of patient that goes through CPR. On the MI, we measure the amount of patients that suffered MI and their ECG was transmitted to the ICU. And people with suspected acute coronary syndrome that were given aspirin. For stroke, we are measuring the stroke recognitions of the team using the FAST scale and hospital alert of patient with suspected stroke. For intubated or airway managed patient, we measure 3 consecutive measurements of end-tidal CO2 to assure that the tube is in place. We also measure for every patient that have pain, a pain assessment scale. And for sepsis, which is kind of a new KPI, we have the sepsis identification. So as Professor Leo, we use the Q-SOFA scale. Actually, the Q-SOFA is a prognostic scale, but since it gives a good indication of patients that have high risk of sepsis diagnosis, and if their score is above two or more, they're in high risk of poor prognosis, then we use it as an identification scale. And what we do is our team, I will show you in a second, but once our team identified the patient as a suspected sepsis with a Q-SOFA score of 2 or more, we give a hospital alert for the patient arriving, and then it would assure a rapid treatment to that patient. And this is my last screen. So the sepsis KPI on our side looks what you see on the right side of the screen, left side of the patient. You see how the screen looks on our tablets. But what we do is once the team have entered the measurements of the patient, the computer automatically draws the measurements into the score. And then once you have a score of 2 or more, we have this icon on the side that pops up, and you must mark if you reported to the hospital whether the patient have a suspected sepsis, who it was reported to, and what time it was reported, and if not, what was the reason. And in this way, we also measure the amount of patient that we transport to the patient with suspected sepsis, and on the other hand, we assure that those patients are reported to the hospital prior to their arrival. And that would be it.
Thank you very much for your presentation. So I'm glad that you all succeeded to have a short presentation, but very you managed to bring to us all the important information that we needed in this short webinar. Thank you very much for this. I think that all of you together, you bring all the needed information. I had a lot of questions for you, but you answer all of them. We know all that the sepsis is a multi-organ failure. We need to start early to treat it. We see that sepsis can present with a wide range of symptoms. We need to find early the warning scores and use them in the pre-hospitals. And I think that you managed to bring this information to all of us. If there are any questions from the audience, or some of you want to say another thing. Chaim, do you have some question for our speakers? No?
I have yes. I have one question, and it is, what do you feel is the future? What is the next advance? We advanced a lot in saving patients in ventricular fibrillation. We are doing better with stroke, with myocardial infarction. What's out there for sepsis?
Yes, Professor.
Chaim, good question. This is why I showed what everybody came up with, or the really lab research showed, like, can we do something to the endothelium or something like this, or immunosuppression. At the moment, throughout the 30 years, only basic medicine helps. Like if the blood pressure goes down, we put in volume. We think sepsis has to do with maybe bacterial infection, so we give antibiotics. But at the moment, I haven't seen any specialized medication which shows that it's acting really positively.
Leo, if I may jump in, so maybe the answer is we need to educate the public better because they reach care too late.
Yes, it looks like because if we still see them arriving at the hospital, yes, it may be too late. And if I see, for instance, the results that given antibiotics maybe even an hour earlier shows some change in death toll, that may be the thing. You're probably, I don't know. There are some countries like Israel or with Maria where you train the EMS service, to look for it. That may be one thing that we still haven't trained them enough so that they overlook the signs of sepsis. And once, of course, yes, they recognize patients who are more into septic shock than into the beginning of sepsis. But these are the patients who will die up to 60% in the hospital.
Yeah, but I would ask Adelaide, Tomer, and Elena, because it seems to me. Yes, please.
I would just add that I think public awareness is very important on that aspect. But on the other hand, I can say that at least in our side, I don't want to say most because I haven't measured it, but it feels like most of our patients comes from elderly houses, and most of them are not healthy individuals to begin with. So I don't think we can educate them. Maybe elderly houses, crews and teams to be more sensitive to the lightest fever or lightest signs of disease. Maybe that would be a benefit on our side.
I agree.
Yeah, but
Me
Tomer,
too. I will just like to add that the future should pass through enhance, I guess, the efficacy of our pre-alarms. Because I guess if our pre-alarms work, these patients will get to the hospital sooner, and they will be given antibiotics sooner as well, and so the mortality will be much lower. And of course, I guess population education is fulcral to surviving sepsis. So I guess that's the future.
Yeah, but Tomer, what you've just said, I have to say, to me is alarming that we accept the idea that someone in an elderly home will get a sepsis and most probably will die from sepsis from a very simple UTI. And that's the reality.
No, I agree. It's something that needs to be addressed. I'm just saying, when we say public awareness, I think we should also aim on that crowd.
Paloma, Elena, Paloma, because you are working a lot with abuse of the elderly.
Yeah. Okay, I would say that the most important issue is it's an early detection and healthcare personnel awareness. So it's important to think about the possibility of being in front of a patient with a suspected sepsis. We don't have too many cases in septic patient, but quite a few. So if you don't think about the possibility of having a sepsis in front of you, maybe you never will diagnose the pathology.
Elena?
We have a lot of sepsis cases, unfortunately, which can come from elderly with comorbidities. They are being in elderly centers. We have sepsis, urinary sepsis, pulmonary sepsis. I think like 1 or 2 cases in my hospital, for example. They are coming in the emergency room every day. I think that healthcare should be taught about recognizing the early signs. The elderly have a lot of other comorbidities. They are dehydrated. They don't move. Some of them, they are immobilized in the beds. So these are factors that are favorizing the sepsis, in my opinion. I also have
one question in the chat, Elena.
Okay,
Did you see it?
One moment.
It's a good question.
I cannot open the chat.
Do you want me to read it, Elena?
I can see it now.
Okay.
Mr. Nanwani and Kapil Laxman asks about what about fluid responsiveness in pre-hospital setting? Do you have experience in passing leg rising echography, cava vein, renal Doppler, or pulse pressure variation or other technique in order to assess fluid responsiveness, especially in long transfers?
I can say for our side, we're using we only have blood pressure, so we're using the map or blood pressure response, and of course the patient clinic, what he presents. We're looking into bringing POCUS into our service soon. So once we'll have the POCUS, maybe we'll have a better tool to assess the vena cava and see the responsiveness in a better way. For now, we're still behind.
But it says that you should not wait until you get a central venous catheter in there. You can even start fluid and vasopressor with just a Branula or so, as long as you don't have a central venous catheter in there.
I think I can talk about the Portuguese context. We introduced POCOs in some of our ALS teams very recently, so I don't have that data to present. However, as it happens, I guess worldwide, we use the clinical context and the signs that the patient shows. And as Dr. Professor Lee was talking. When the fluid responsiveness is not being the best, even our ILS teams have to talk to the coordinating doctor within the central to validate the introduction of noradrenaline. So in longer transportations, this is our reality right now. But as it is, I guess that further I guess even in this year, we will have the POCUS data to assess this specific question. But I guess POCUS in every occurrence, but specific in sepsis is going to be a good thing to have in the pre-hospital setting. That's my personal opinion.
We also introduced the focus on the ambulances, but for the moment we don't use it for identifying the sepsis. We are using just for trauma.
I'm sorry, not for sepsis, but for to assess the inferior vena cava, to know if the patient after a determined amount of fluids is already filled or not, and if it's better to initiate the noradrenaline that we do empirically now. So we have an image that can further say that we are going to introduce the noradrenaline sooner than later. That's it. That's what I'm trying to say. Sorry.
I understand. Yes, Professor.
I have one question to all of you who treat sepsis patients. Have you ever seen a patient without bacterial infection?
What do you mean? I'm sorry.
Look, we're using antibiotics. Okay, and it shows that antibiotics are, let's say, helping. But I mean, we know all as doctors or medical personnel that antibiotics help on the bacterial side. So this is my question. Have you ever seen all the sepsis details, but a negative blood culture?
Negative blood cultures are very frequent, so I guess we don't have to think about the blood cultures specifically. However, not for my specific experience in the EMS, but for my experience in the hospital, in the emergency room, I saw specifically in the COVID-19 pandemics sepsis with a viral context. However, we don't know what's the pathogen involved. Of course, we gave them the antibiotics.
Antibiotics, yeah.
Of course.
As Dr. Esteves just said, in the hospital context, we have encountered maybe fungal infections or virus infections. Maybe not in the pre-hospital setting because it's maybe too early, but especially in immunocompromised patients, such as cancer patients, we do see fungal infection, especially, or aspergillus or whatever.
I also have a question. What about vasopressin in sepsis? Do you have experience with using vasopressin?
Again, we have experience with vasopressin, but in the hospital setting, not in the pre-hospital setting. And this is associated with not.
You have no sound.
Kapil, you are mute.
Oh, sorry. I muted myself. Well, I was saying that I do have experience with vasopressin in the hospital setting, in the ICU setting, associated with noradrenaline, especially in the early stages. as a second vasopressor instead of using adrenaline, for example. But we do have experience with vasopressin. I should say not the best experiences because we have encountered more problems with distal perfusion and microcirculation with double vasopressor therapy, but maybe not only due to vasopressin, but because of the patient's characteristics, microthrombi, etc.
Thank you. What about you, Professor Latasch? Do you use in association between vasopressin? We cannot hear you. You have your microphone.
Yeah, I put it on now because I'm coughing all the time. Sorry about that. We go strict by the protocol. We start with norepinephrine, and then if we see it's not enough, then we go to the next step. And we look also on the other side that there's enough volume available to the patient, and actually not before we see if the volume is working or not. We start with vasopressors.
Thank you. And regarding your question, your earlier question, we have a response that yes, in viral pneumonia, regarding the sepsis that you were asking earlier. So I also have another question. I don't know, maybe I should keep it for the experts' opinion, but I want to ask what about the role that technology, such as artificial intelligence or machine learning, can play an important role in improving sepsis diagnosis and management?
Who wants to start?
It's a difficult question. I just can say that now KnowEMS is invested in a system that as the EMS teams fill the proper fields, the alarm is generated, the alarm of sepsis is generated automatically. So I guess that if we can use artificial intelligence to this, I guess it will be usable. However, I think sepsis is really complex and it will need always a human factor. That's my opinion, and I'm very young, so.
I would suggest that it may give us more ideas, because we all know that if you go to certain medical questions, the overview in literature is really hard to get it all. So artificial intelligence may be the way that at least we know at one point what other countries or labs are doing as research, what are the results of those, and to put it all together in one main thing. But I don't see at the moment, because we know what to do. We're not looking at the results, but we know how to progress in case we see a sepsis. So artificial intelligence in that case, I really don't know. And I think Maria is right to say at the end the human has to decide, because in some cases we decide to take everything away from vasopressors to fluid from the patient, and miraculously in 2 or 3 days you see a sudden change of the effect. And so yes, I think that you still need humans to think what else can we do aside from artificial intelligence.
Thank you for your answers. If there are any other questions?
Yes, I mean, just to continue with this hot topic, I would like to add, yes, I agree, we need humans controlling what we're doing. But I do feel artificial intelligence can play a very important role, first in diagnosis, as Dr. Esteves said, in recognizing those rapid response in those clinical criteria. And on the other hand, we've spoken about antibiotics. We saw in Portugal there's no antibiotic, no blood cultures, but we know that antibiotic therapy is very important, and we have a lot of drug resistance in our environment. So if artificial intelligence can help us select the correct antibiotic and tell us, hello, this is not just a simple ceftriaxone. This patient needs a meropenem or needs a ceftazidime-avibactam because we've got this multi-drug in this area specifically from where this patient is coming. I think this is something already hospitals use. Each hospital has their own antibiogram and their own fauna, to call it in some way. So maybe this is somewhere artificial intelligence may help us.
Thank you very much for your answer. Yes, it's indeed good thinking regarding the antibiotics, using using artificial intelligence that way. Is there anyone that want to add something? Or Michelle, do you think we can?
I think there have been plenty of very informative presentations and a great discussion. Really, really thank you. And for our experts, I would say, please stay in this room. And for all the others, thank you for having us today. And I've posted in the chat a link where you can get a certificate of attendance if you want to. Just fill in everything and then we'll send it to you. And as I said in the beginning, we have our webinars on every first Thursday of the month. So next month in May, there will be another one. So check out our YouTube channel, check out our LinkedIn, and stay up to date, become a member of our network, and have a nice evening. Thank you.